Well, hello again. It's Jason Renault with the Alternative Mobile Services Association and AMSA Talks. Today I'm with Rachel Odes. Hi, Rachel.
Hey, nice to see you, Jason.
Nice to see you. Rachel is with the University of Wisconsin School of Nursing, and she's written a very interesting paper, which we're going to discuss today. Rachel, let's get started by telling us a little bit about yourself and how you got to this area of inquiry.
Well, thanks for having me today. My background is in psychiatric mental health nursing. I have always been interested in mental health, and so that's always been my focus as a nurse. And I was living in the San Francisco Bay Area before moving here to Madison. And I got out of school and went to go work. Well, I worked in a bunch of different mental health settings across the Bay Area, San Francisco area, and landed in Alameda County, which is where Oakland is, very big hospital system, safety net system. And I really, really loved the patient population and the setting. And so I worked at John George Psychiatric Hospital for about 10 years, and I did a few different roles there, staff nurse, charge nurse. Learned really about the mental health care delivery, sort of on the acute care side. And over time, really came to see some of the shortcomings and some of the challenges that we face in mental health care delivery. So decided to go back to school and get a PhD. Was interested in two things primarily. One is health policy, and two is occupational health and safety. So I was really interested in how the workforce was able to sort of fit in to the healthcare delivery system. So I studied actually in my PhD program workplace violence towards healthcare workers and looked at California had a new statute, trying to protect workers from violence on the job. So I was well positioned to actually look at the implementation of that new standard and do some research around that. So I finished that and then, really had this sort of transition in my thinking about how we keep people safe in healthcare systems. I really saw the challenge in having so many people who were hospitalized against their will, who were on an involuntary basis in the setting like where I worked. And so that really led me to look for other types of models, other types of approaches to bringing people the mental health support or treatment that they needed. And I was fortunate in San Francisco Bay Area, there were a bunch of these new approaches, these new models, which had been rolled out. And I met, in my postdoc, I met Dr. Matt Goldman, who was at University of California, San Francisco, was where I was. And I joined his team to look at implementation of the street crisis response team in San Francisco and looked at it. He had a really great project looking at multiple angles on implementation. So, what kind of metrics, but also what kind of qualitative experiences people were having. And that was how I also started this project around the workforce. So I was in San Francisco and getting to know SCRT and crisis system there. And I wanted to know, kind of parallel to what I was looking at with the nursing workforce, I wanted to know who's doing this work, what is this job? And how do we make it sustainable? If we think these models are good, sort of how do we build scaffolding infrastructure to make that possible? And so that brought me here to Madison, where I'm in the School of Nursing and continuing on that path and trying to ask questions about implementation for these models. So long answer to your question, Jason.
So you're studying in this paper San Francisco's SCRT mobile team
Mhm.
and the Madison Cares mobile team. They're very different teams.
Yeah, yeah. I mean, it's very as you can tell by my biography, a little bit of a combined data set by convenience, because of my move across the country. But yeah, so I collected data in San Francisco, and it was actually both the SCRT and the sort of traditional crisis responders, who are the people who go not through 911. So there's a little bit of a combined group there. And what they share, so SCRT and Madison Cares are both paramedic-based teams, where they have a mental health provider alongside the medic. And so there was some similarity there, but the cities are very different, and sort of the mandates overall of what they're expected to do are very different. So that was pretty interesting to put all these interviews together and to try to tell, one story about this workforce, based on what we found.
There doesn't seem to be a homogeneous ideal team at this point. There seems to be, I don't know, every team is, every program is different. Sometimes every team within every program is different. How did you match those two?
Yeah, I mean, it's a really good question. And, you know, the what stood out to me is you know, the interdisciplinary collaboration that's at the core of what these teams are. You need people who have a real sense of the community or the street environment, like what, and this is really where the medics come in, what is a safe scene to engage in? What
Mm.
are the considerations that you need to have when you're gonna, be in an environment that is unfamiliar to you? So that was really important. And having people who have the clinical background to have a really long, difficult conversation with somebody. And so I've gotten involved here. It's been very fortuitous, but I've gotten involved in some of the training for community paramedics. So the CARES team, and actually in San Francisco as well, they hire people who are community paramedics. So they have an endorsement on top of their regular license to do some sort of more deeper assessments and kind of longer conversations with people. But they still, it's not usually their starting point, people
No,
who are EMTs or paramedics, right? They
they're
want
all
to have,
hustle, run, run, run. How do they
right.
get to a long conversation?
Yeah, so I've been able to, it's been cool. I've been able to do some teaching around motivational interviewing, which is one of those things that's like a foundational concept for mental health providers. And
Mhm.
really what it is telling them that they need to slow down. They need to take a deep breath and recognize that whatever the problem is not going to be resolved in the next 20 seconds, and that they may just need to be there for somebody to vent or to talk about what's happening in their life, or to have some basic need met, like water or food or a blanket. And it's a very different mindset than how a lot of people start out in that field. And, it's parallel. It was very parallel to me in nursing,
Hmm.
because I think that was a lot of the tension that we saw in the acute care setting in the hospital, is that people want to enforce their timeline on something that needs time and space to breathe. Like if somebody's having a crisis, or even if it's, not an acute crisis, if it's any kind of mental health concern, you can't rush that conversation. And so it's something that nurses have to unlearn, and it's something that I think medics have to unlearn, probably more so.
So this is a real nuanced question in the hiring and onboarding of any staff person is, do they have this patience built into their urgent awareness of situational awareness?
Yeah, and I mean, it's been great for me to get some access to the leadership of these teams, and just in this field and working this area and research, getting to know people in different parts of these organizations who are making the hiring decisions, because that is one of those things, that you need to be able to recognize as the person doing the interview, like you're looking for this extra thing that somebody has, which is openness, the ability to recognize that, you need to let the conversation breathe sometimes, and the ability, and it's a flexibility, I think, and not having to be in control of an encounter. And it's a hard thing to assess for, I think. And that's one, I'm sure people who've done this hiring recognize that. It's a hard sort of thing to put your finger on when you're just meeting somebody for 15 minutes in an interview.
Let's dig into your research here and the paper that you present or are presenting to the APHA, and then is going to be linked below this video, so people can go and read the full paper themselves. How did you get started with this?
Yeah, so this paper is as I described, is the combined, it presents the findings from this combined data set, which is half people from San Francisco, responders from San Francisco, and half from Madison. And so, there's sort of two qualitative projects that are coming from this data set. And so I can talk about the one which will be linked to the paper, which we'll share with the audience here. But this one is really looking at, so it's drawing from my occupational health perspective. So there's a sort of famous framework in occupational health research, which is called total worker health, and
Mm.
million frameworks for assessing occupational health and safety. But this is one. And what it tries to do is say, there's a holistic experience of somebody's work life. It's not just, so, if you go back to sort of old school occupational health, industrial hygiene, you're looking at chemical exposures, heat exposures, right? Like there's a sort of traditional set of hazards that you need to be aware of to keep somebody safe on the job. The total worker health approach is a little bit more holistic, and I think is good for a job like this one, where you do have physical or other types of hazards that you're going to encounter in the environment, but you also have trauma and burnout and sort of organizational challenges that are important and very sort of consequential for somebody's longevity at their job. So that framework allows you to sort of look at those things. And so we tried to use some codes that came out of that framework to read these transcripts. So there's 22 of them, and to identify the things that stand out about each one of these codes. And so it's really looking at, physical, like I said, the basics, physical environment, but also the policy environment. What
Mm.
is the relationship of the team to the community? And I think that's a particularly important one in a job like this, because people who are in these teams, so both of the teams in San Francisco and in Madison were new when we're conducting these interviews. And people are being asked to step into a role which really didn't exist before, right? I mean, this is conceived of as this reimagining of public safety. And so, people kind of have to live into that and try to figure out how do they fit, if they used to be a firefighter, they used to be a paramedic, or they used to be a social worker. This is sort of a whole new expectation. So that's an overview of the project, and it's really just the story of what people told us about these different occupational health domains, and how we can try to support this workforce. I think is where the takeaway is trying to go.
When I talk to people, especially EMTs on
Mhm.
teams, they often talk about what they love about the job is the variety, is that every day it's a new problem, new set of problems. And that senses to me that they're still in the thrill seeking mode. that
Mhm.
they're still looking for some energy and some adrenaline. How do you assess the motivations of people to join these teams? How do you think about balancing the heroic nature with the that long, awkward conversation?
Yeah, I like that question. That's a good way to frame this, I think. Because so we did spend a lot of time talking to people about where they came from occupationally, like
Hmm.
what was their progression to get to where they are and sort of how did they decide that this was something they wanted to do. And yeah, it's interesting. I think a lot of the medics who I talked to felt like they were done with the, chasing people around and like scooping people up and rushing them to the
Hmm.
emergency department. And they were people who really recognized the inefficiency and, sometimes just the harm of pulling people out of community environments to bring them to the emergency department. Here in Wisconsin, I mean, we have a pretty horrendous I was a little bit floored finding out how, the involuntary detention process
Yeah.
worked here coming from California. So law enforcement has to be involved here, which is really, stigmatizing and dangerous for a lot of people. And so I think a lot of folks who had been working in the MS side were like, okay, we recognize something is not working about this. And so they kind of had come to their own conclusion that there was something more positive and more sustainable about doing this kind of work. It's also, a couple people brought up to me, and this is sort of again on the traditional occupational health assessment. They're like, it's really hard on my body to pick people up and haul them
Mm-hmm.
all day long.
Mm-hmm.
Sometimes in San Francisco, people are going up into SROs and trying to bring them down the stairs and like,
That's always
you
a problem.
know, yeah, it's really dangerous. And just, you're prone to injuries. And so this work was like, well, this is actually less, right? It's a less hands-on.
Yeah.
And so it's a different animal.
So in the opposite question to the motivation question is, did you find some reasons that people leave these teams, that there's turnover, that people say, this is not for me?
Yeah, that's a good question. And I think I did ask people about their intention to stick around and to see where they felt like this fit into their career. And I think especially on the like the social worker behavioral health clinician side, it's a tough ask for them if they have not worked in an environment that is long shifts, like off hours, right? Weekends. And so there's a little bit, and that was again what sort of came out of having these two types of workers together was like, the people on the EMS side were like, oh, this is better, like we're used to this,
Hmm.
versus people, who and they're so in demand. That's the other thing. People with clinical training and who have worked in like a lot of people had worked in CPS or crisis already. And so like these are very employable people. Like they could work in a lot of places.
Hmm.
And then like, do I really want to have a job where I'm stuck? Like I can't go to soccer games. I can't make it to, my life is
Hmm.
sort of impacted by the way that this emergency response job is structured. And so that's a real challenge. And I think that is like, again, one of the different, features you have to keep in mind when you're bringing people from different disciplines together is what is the starting point? What does their baseline job look like? If they're just coming out of school or whatever, because you need to be able to frame a new opportunity
Hmm.
for those people in a way that is sounds good to them. Like at least there's some trade-off in terms of extra days off or extra pay, right? I mean, there's things you can do to incentivize people, but if it's just a much harder schedule, and much more intensity on a day-to-day basis, that can be a pretty hard sell.
Yeah, it's one of the best parts of my experience is speaking to team members who it's really clicking with at this moment in their
Mhm.
life and their career and their psychology that there's they are hungry to go out and meet new people and solve new problems. And that's just really exciting. Let,
Yeah.
let me ask you about your past research. You've been paired with some of the best researchers in the country with Dr. Goldman, Dr. Leopold, and others. The research is really, we're really hungry for this to know more about not just this workspace, but the work itself. Where do you see research needing to go in the next year or so? What do you see the important points to look at?
Yeah, I mean, I definitely am learning. I'm trying to learn as much as I can from those folks who are who've been doing this for a while. And Dr. Amy Watson have had a chance to talk to a few times, and she's really leading the way on this. Some of these workforce questions, and I think yeah, I mean, I think there's a lot of opportunity to understand what are the most meaningful outcomes that we can track for these types of interventions. And I think, what I learned from working with Dr. Goldman in San Francisco somewhat is that we need to be, it's hard to put your finger on some of these outcomes. You
Hmm.
need to be flexible because as researchers, because these teams are working in really complex environments where we don't have a clear cause and effect that we can point to. And so trying to be sort of flexible in our assessments of what is meaningful to one particular system or another. And that's a hard line to walk as researchers because we want to find lessons that are generalizable. We want randomized controlled trials, like we want things that are A leads to B. And so trying to build in the specificity of environments that are extremely complex and have a lot of competing factors influencing what happens to somebody in the course of their illness. And so I think the other thing is, you know, trying to define what the mental health crisis episode is itself. And that's another
Mm.
thing I learned both in San Francisco and the research that I've done here. I think, in this field are using crisis as a way to sort of capture what's happening right now with
Yeah.
the sort of policy movement. But for people who are living with mental illness and are sort of this is their day-to-day life, like they may engage with one of these teams in an encounter that doesn't represent a crisis to them.
Right.
And so it's kind of like arbitrary, right? It's our sort of convenience that we're capturing this as a crisis intervention. But I think trying to grapple with that will help us get better data because it's like, are we trying to find something that isn't there, right? If somebody sees a team and basically their family called the team because they were having a bad day, right? But we're not going to see a big change, even though this is a good intervention. We're not going to see a big cause and effect there because the crisis was not really a crisis. So I hope I'm not getting a little too esoteric here, but
Not at
I just,
all. I mean,
okay.
this is a problem that everybody sees. Whose crisis is it? The 911 dispatcher says the crisis is the caller. You know,
Yeah,
the
yeah,
the funder's perspective is that we need a reason to go out and see this person who's been in crisis forever.
yeah.
So it's a bit of a false word here that we use in multiple ways, but it's sort of maybe based on the fact that the mental health system was not designed with the patient's interest in mind.
I mean, I think that's a really good way to put a finger on it there because I think that's really, it is, we are working in an environment where, right, you're saying like exactly what you're saying. We need funders to agree to fund a specific intervention as opposed to a holistic spectrum of care, which is really the most appropriate way to
Right.
treat mental health, right? Like one particular intervention is not always going to work. And so, yeah, I think that's it, right? And that's always our story. There's always a little bit of a square peg, round hole when we're trying to do policy research. It's like, well, this isn't exactly what we mean, but it's still what we have to work with. So, no, I appreciate that question.
Square peg in a round hole is good. I kind of like bullet hitting a bullet. The
I,
chance of your solving the problem here is really minute.
yeah.
So, I have a lot of skepticism about this whole area, as I have optimism and skepticism sort of mixed up together.
I mean, I think that's a good place to live right now, Jason. I mean, I think that's like, I mean, that's the authentic place to live. I don't like using that term, but like, I mean, because I don't know that there's any other way to go about this, right? I mean, we have to, um, and I think pe for people who've been like, I've worked in mental health for a long time, and it's sort of like you see things that become a flash in the pan where people get excited, and there's things that gain momentum. But building a sustainable project where we have, funded systems and we have, the evidence that we need to sort of evaluate how they're doing. I mean, I think there's a vision that we want to contribute to get there. At the same time, you sort of recognize the motivations of a lot of these players, and it's hard to feel like truly optimistic about things moving in the right direction. Even though I do think there's a lot of openness in sort of the community, and I teach undergrads, so that's where I get a little bit of hope in terms of the stigma reduction that's happening around mental
Yeah.
health broadly, which I've been able to witness in the last 10 years. And the young kids in my class who are willing to talk about their own mental health and want to actually engage with the topic. So I get a little bit of the energy from that, where it's like, okay, this is broadly moving in the right direction, despite the things that are happening sort of at the upper echelons that we are clearly concerned about. So
Well, those undergrads are so lucky to have you. That's just your wealth of resource, wealth of information. Thank you for your research. Thank you for your work and interest in this mobile services area.
well, thanks for doing this project, Jason. I'm happy to be here.
Take care.